Nutrition and weight management. Obesity. Outline. Objectives. Definition. Pathogenesis. Environment. Genetics. Psychology. Neuroendocrine. Clinical assessment of the obese patient. Anthropometric and body composition data. Standard classification of overweight. Waist-hip ratio. Health history. Diet history. Implementing the nutritional care plan. Nutritional management in obesity. Determining energy needs. Behavioral modification. Bariatric surgery. Childhood obesity. Complication due to obesity. Objectives. To learn the different methods of assessment and nutrition care plan. To know the etiology and the complications of obesity. To understand the nutritional management in the prevention of obesity. Definition. Obesity can be defined as an excessive accumulation of fat in the body, either general or localized, and should be viewed as a chronic disease. Pathogenesis. Obesity is multifactorial in etiology. Some of the factors are described in the following list. Environment. Genetic. Psychology. Physiology. Neuroendocrine. Environment. Early life environment could determine obesity. Birth weight. Parental obesity. Overshows of TV a week at the age of 3. Short sleep duration, less than 10.5 hours night at age 3. Rapid weight gain in the first couple of years. Exogenous factors that may predispose to obesity include increased energy intake or decreased physical activity. Availability of high energy density foods at low costs has increased. Portion size in fast food and full-service restaurants, as well as the packaging of individual serving. Genetics. Genes clearly influence the development of body size, and hereditary play a definite role in the human obesity. If neither parent is obese, the offspring have a 10% chance of becoming obese. Having one obese parent increases the risk for obesity to 40%. If both the parents are obese, the risk raises to 80%. Plasma concentration of leptin, or hormone released by adipose tissue, normally increase when fat stores are high. This signals to central nervous system to reduce food intake. Psychology. Overeating may occur as a response to loneliness, grief or depression, learned response to external cues, for example, food advertising, or the fact that it is mealtime, rather than the internal cue of hunger. Neuroendocrine. Neuroendocrine abnormalities causes obesity in fewer than 1% of cases, and those that are more likely to cause obesity. Prader-Willi syndrome, characterized by excessive appetite and inappropriate food-seeking behaviors, can lead to morbid obesity. Increased secretion of ghrelin, a hormone released by the stomach, stimulates food intake, but disorder in ghrelin regulation appear to be very rare. Leptin deficiency is uncommon. It is possible that some obese individuals are resistant to the effects of leptin. Adiponectin and resistin have a role in the body weight regulation, but their importance in contributing to the epidemic of obesity remains unclear. Clinical assessment of the obese patient. The primary objective in assessing obesity is to estimate the amount and distribution of body fat. Various tools are used to assess it, includes anthropometric and body composition data, health history, diet history. Anthropometric and body composition data. This is a measurement of body size, weight, and proportions. It includes height and weight, circumference, waist, hip, arm, body fat. Height. Height is the most frequently misreported value. It is useful to ascertain height by standard measurement in the clinic using stadiometer or other reliable method to the nearest centimeter or half-inch. Height measurement are useful for calculating appropriate weight for height, body mass index, nasal energy expenditure. Weight. Weight is a sensitive indicator of nutritional status. The body mass index, BMI, a standard which relates height and weight mathematically, is often used to determine health risk. BMI equal to weight in kilograms upon height in meters square. Standard classification of overweight. Serial number in adults by BMI. BMI kilograms per meter square. Risk of comorbidities. 1. Underweight, less than 18.5. Low risk. 2. Normal range, 18.5 to 25. Average. 3. Overweight, greater than or equal to 25. 4. Pre-obese, 25 to 30. Increased. 5. Obese, class 1, 30 to 35. Moderate. 6. Obese, class 2, 35 to 40. Severe. 7. Obese, class 3, greater than or equal to 40. Very severe. Waist-hip ratio. Waist-hip ratio is a way of measuring where body fat is stored. It is an indirect indicator of intra-abdominal fat. Waist-hip ratio is calculated by dividing the measured waist circumference by the measured hip circumference. W/H equal to waist to hip ratio, WHR. Indicator of risk. Men, WHR greater than 0.85. Women, WHR greater than 1.0. Health history. Obesity is associated with numerous health risks, which are summarized as very high risk, high risk, other risk factors. Very high risk. It includes presence of CHD, myocardial infarction, angina pectoris, and coronary artery, surgery or other procedures, sleep apnea, etc. High risk. Cigarette smoking, hypertension or current use of antihypertensive medication, high concentration of LDL or a borderline LDL concentration, impaired fasting blood glucose, family history of premature CHD. Diet history. Diet history includes the following criteria: usual food intake, meal and snack patterns, portion size, food preparation methods, activity pattern, type, amount, intensity. Implementing the nutritional care plan. It involves providing both the appropriate meal plan and education. Involve client and family in setting goals. Ensure that care plan fits into overall management plan for the client. Develop strategies to achieve goals. Counsel client and significant other. Refer to other members of the health team. Nutritional management in obesity. The dietary approach used to achieve weight loss and long-term weight maintenance must satisfy by 3 criteria. It must be based on a sound scientific rationale. It must be safe and nutritionally adequate, and it must be practical and applicable to the patient's social and ethnic background, so as to be conducive for long-term adherence. Determining energy needs. There are several methods used to determine energy needs. The Harris-Benedict equation for basal energy expenditure, BEE, which is often used to estimate the minimum amount of energy needed by the body at rest, uses age, height and weight. For men, BEE equal to 66.5 plus 13.8 into weight plus 5.0 into height minus 6.8 into age. For women, BEE equal to 655.1 plus 9.6 into weight plus 1.8 into height minus 4.7 into age. W. Weight in kilogram. H. Height in centimeters. A. Age in years. Resting energy expenditure for men. REE kilocalories per day equal to 1.0 into weight into 24. For women, REE kilocalories per day equal to 0.95 into weight into 24. BEE and REE are multiplied by an activity factor to estimate total energy expenditure. Energy needs based on weight and activity level. Sedentary, moderate, active, overweight, 20 to 25, 30, 35, normal weight, 30, 35, 40, underweight, 30, 40, 45 to 50. Calculating energy. A 75 kilogram male who is 1.8 meters tall doing moderate level activity would require BMI equal to weight in kilograms upon height in meters square equal to 75 upon 1.8 into 1.8 equal to 23. This person is in the normal weight range and he is doing moderate activity. Energy into weight. 35 into 75 equal to 2,625 kilocalories per day. Subtract calories if weight loss is desired. Generally, 500 or 1,000 kilocalories per day can be subtracted from current intake to produce a 0.5 to 1.0 kilogram per week weight reduction. Calculate the grams of carbohydrate, protein and fat from the exchanges and determine percentage of total calories contributed by each macronutrient. 1. Grams of CHO into 4 into 100 per total calories. 2. Grams of protein into 4 into 100 per total calories. 3. Grams of fat into 9 into 100 per total calories. Adjust exchange as needed to reach goal percentage for each macronutrient. Recommended treatment for obesity. Determine the level of obesity and the specific intervention needs of the client. Example, elevated blood lipid. Set realistic goals. Assist the client to set his or her own short, medium, and long-term goals. Distribute calories over approximately 6 meals for the day, including snacks to prevent overeating. Provide adequate fluids to aid excretion, at least 8 glasses of water per day. If there is fluid retention, decrease sodium intake. Increase the fiber content of the diet to encourage longer chewing, create more bulk, and increase satiety. Decrease the intake of high-calorie foods such as fats and alcohol. Avoid severe dietary restrictions, since very low-calorie diet may lead to reduced REE and affect the rate of weight loss. Schedule follow-up appointments to monitor progress and monitor weight using the same scale. Encourage regular physical activity according to doctor recommendations and client's preference. Ensure that nutritional counseling is highly individualized. Encourage the client to participate in a support group and facilitate family involvement. Encourage client to record fluid intake daily to be able to verify reduction of calories through fluid. Behavioral modification. Behavioral modification is an integral part of such programs because changing behavior is essential to changing lifestyle. Behavior strategies for weight reduction should focus on 3 components: self-monitoring, stimulus control, and self-rewarding. Encourage the patient to chew food slowly and put utensils down between bites. Never shop for food on an empty stomach. Make out grocery shopping list before starting and do not add to it as you shop. Leave a small amount of food on your plate after each meal. Fill your plate in the kitchen at the start of the meal. Do not put open bowls of food on the table. Eat in only 1 or 2 plates. Example, kitchen and dining room. Never eat while involved in any other activity, such as watching television. Do not eat while standing. Keep low-calorie snack available at all times. Reward yourself for weight loss. Drink a glass of water before each meal. Drink sips of water between bites of food. Physical activity. Moderate physical activity for 30 minutes most days of the week is sufficient to achieve cardiovascular benefits, but more exercise. Exercise is important for weight loss and weight maintenance program because contributes to weight loss in overweight and obese adults. May decrease abdominal fat, increase cardiopulmonary fitness. Regular physical activity is an essential component of any weight management program and complement dietary measures. Activities involving gross movements of large muscles promote fat loss while conserving LBM. Aerobic exercise is especially effective in reducing visceral fat. Drug therapy. Pharmacotherapy does not induce long-term weight loss. Drugs currently available for weight loss fall in 2 classes: those that both suppress appetite and stimulate energy expenditure, those that promote malabsorption. There are 2 drugs used to treat obesity. Sibutramine suppresses appetite, is the only drug in this class approved for long-term use in weight control. Orlistat, an inhibitor of pancreatic lipase that results in decreased digestion and absorption of fats. Drug. Adverse effects. Use of sibutramine cause increase in heart rate and blood pressure, heart palpitations and vasodilation. Use of orlistat cause decrease in absorption of fat-soluble vitamins. Decreased fat absorption results in soft and oily stools, flatulence, incontinence, and possible link to breast cancer. Bariatric surgery. An individual with a BMI above 40 or a BMI above 35 plus a serious obesity-related complication who has failed to lose weight with more conventional methods may be considered for obesity surgery. Two surgeries are used. Restrictive procedures, which limit the capacity of the stomach to store food and cause the individual to feel full quickly. Malabsorptive procedure, which bypass a portion of the intestine it includes. These include esophageal banding, gastric restrictive surgery, and duodenal bypass. Surgical procedures effectively limit food intake by reducing the capacity of the stomach and suppress hunger by reducing production of the hormone ghrelin. Childhood obesity. In dealing with obese children, frequently the goal is to achieve weight maintenance. As the child grows in stature, weight for height then becomes more appropriate. The main cause identified are intake of energy-dense foods and lack of physical activity. Obese children are sometimes characterized as being unhappy, lazy, mean, not having friends. Complication due to obesity. Serial number. Type of problem. Disease, symptom or difficulty. 1. Cardiovascular or respiratory. Hypertension, CHD, varicose vein, sleep apnea. 2. Endocrine or reproductive. Type 2 diabetes, insulin, infertility, preeclampsia. 3. Gastrointestinal, gallstones, fatty liver. 4. Musculoskeletal and skin. Osteoarthritis, skin irritation and infection, striae. 5. Malignancies. Cancer of colon, rectum, prostate. 6. Psychosocial. Social discrimination, poor self-image.